All right, it's 12 o'clock, so I think we'll go ahead and get started. Welcome to our webinar entitled Technetium-99m Pyrophosphate Evaluation of ATTR Cardiac Amyloidosis, Case-Based Application of the New Interpretation and Reporting Recommendations webinar. Our webinar today is sponsored and hosted by the American Society of Nuclear Cardiology, and support for this activity has been provided by Pfizer. Next slide. I am Jamie Bourque. I'm an associate professor of medicine and radiology at University of Virginia and medical director of nuclear cardiology in the stress lab there. And with me are our speakers, Dr. Ed Miller, who is associate professor of medicine and radiology, director of nuclear cardiology in the cardiology fellowship program at Yale, and Saurabh Malhotra, director of advanced cardiac imaging at Cook County Health, an associate professor of medicine at Rush Medical College, and then Brett Sperry, an assistant professor of medicine, University of Missouri, Kansas City, co-director of the cardiac amyloidosis program and at St. Luke's Mid-America Heart Institute. Our agenda today will be, I will provide a brief interpretation reporting update, and then we'll have talks on PYP image interpretation, looking at grade 0, 3, and equivocal, when SPECT imaging is critical, real-world diagnostic pitfalls, and then hopefully we'll have a good amount of time at the end for a robust expert panel discussion and question and answer. And we just have to state that there is currently no official FDA indication for the use of technetium-99m pyrophosphate in the diagnosis of cardiac amyloidosis. So just some quick housekeeping tips. Please mute your personal phone, mute your computer audio, and turn off the video if you're not asking a question. And I think probably the best way to do this is for you to send your questions through our Zoom chat feature. If we get through all of those questions, we may have time at the end to have folks put their video and audio on and ask questions. But if you can send it through Zoom chat, that's probably easier. And please, if you are going to go on video and audio, please participate from a quiet area without background noise. So I will start off by giving an overview of interpretation and reporting. Here are my disclosures. So our learning objectives for today are, we want you to be able to apply a structured approach to the interpretation of technetium-99m pyrophosphate images for the evaluation of ATTR cardiac amyloidosis. And we want you to be able to assemble a comprehensive technetium pyrophosphate report using best practices. I want to highlight the fact that there are several resources available to you. One is a two-part expert consensus document that Sharmila Dorbala and I co-chaired on, which was multi-societal and brought together really experts in the field, both in imaging as well as our clinical experts in cardiac amyloidosis. And the first part looks at the evidence base and standardized methods of imaging. And then the second part provided a rigorous expert panel derived diagnostic criteria and appropriate utilization rating. There is also a technetium pyrophosphate imaging practice points document in cardiac amyloidosis that provides a lot of good tips. But I wanted to highlight the fact that we actually ended up publishing an addendum to our consensus statement because as the use of pyrophosphate imaging extended to lower prevalence populations, there were several issues that came up. One was that with a large focus on the heart to contralateral lung ratio, without confirming diffuse myocardial uptake on SPECT imaging, there was a fair amount of incorrect diagnosis happening, and folks were being sent to centers of excellence that had been on medications who frankly did not have cardiac amyloidosis. In particular, excess 1-hour blood pool activity was being interpreted as positive. And then there is the substantial concern that if the ATTR PYP imaging is done without lab testing to rule out AL cardiac amyloidosis, that there is the possibility to miss that very substantial disease, which has a different treatment course and is highly morbid unless treated fairly quickly. So that is definitely not something that you want to have happen. And so we'll highlight sort of ways to get around that. So the following interpretation and reporting steps that I'm going to go through incorporate the new addendum recommendations. So as far as your interpretation, the first step is to perform a visual interpretation. And as part of that, you want to confirm that there's diffuse radiotracer uptake in the myocardium on SPECT imaging. You can't do this on planar. This has to be done on SPECT imaging. And you want to differentiate myocardial uptake from focal uptake that may be from a subacute myocardial infarction, or more commonly from overlapping bone. If myocardial uptake is present when you do that visual inspection, then you can proceed to step 2, which is the visual grading. If there is no myocardial uptake present and there is no blood pool uptake present, then the study is negative. The visual grade is 0 and you're done. However, if there is blood pool uptake, you need to differentiate between the myocardial uptake and the blood pool uptake. And so if the imaging was performed at 1 hour, which is typically more when you're going to see myocardial, blood pool, retained blood pool, then repeating imaging at 2 to 3 hours is recommended. Stated differently, sorry. So the addendum actually recommended that imaging be performed at 2 or 3 hours. If imaging is performed at 1 hour and there is excess blood pool activity noted, then it's important to repeat the imaging at 1 hour. And there have actually been studies, including by our own Dr. Sperry on the call, looking at 1 hour versus 3 hour, that have shown that it is definitely possible, when carefully identifying myocardial uptake, to do imaging at 1 hour. I will say that my personal experience has been, we've done both for a while, that it's a lot easier to interpret at 3 hours. So I think my recommendation would be that if you're a lab getting started in this, that 3 hours is the easiest way to go initially. There are certainly efficiency advantages to imaging at 1 hour, and especially if you're incorporating CT imaging to be able to very clearly see where the myocardium is, to see if there's myocardial uptake, then that also helps at performing imaging at 1 hour. So the second step would be semi-quantitative visual grading, and I'll go through the scale. And then we've sort of moved the HCL ratio, heart to contralateral ratio assessment, to a step beyond that. And that's something that can be performed when applicable, but does not necessarily need to be performed in every case. So there's been a little bit of a de-emphasis on the planar assessment of HCL ratio. So here is visual grading, and you can see that there are 4 grades ranging from grade 0 to 3. Grade 0 on the far left has no myocardial uptake. You can see there's no uptake on the planar images, and when you look at the SPECT, it's very clear. There's maybe just the very tiniest little amount of uptake there, but you can see that the ribs are very bright, and so this is a grade 0 lack of uptake negative study. You see grade 1, where the uptake is less than the ribs. You can see that the ribs are not quite as bright. A little more is in the myocardium, and you can start to see the cardiac silhouette fairly clearly on the planar imaging. Grade 2, you see more robust uptake, and this is where the uptake is equal to the ribs. You can see that on the SPECT imaging. And then grade 3, also fairly easy to discern, where you see very clear myocardial uptake on the SPECT images, substantially greater than the surrounding ribs. And you can see the cardiac silhouette very clearly on the planar images, and even see that there's kind of a mid-cavity, you can see the cavity has less uptake in the middle. So this visual grading process is semi-quantitative, and you want to differentiate absent from focal, from diffuse, or a focal on diffuse pattern of uptake. So the heart to contralateral lung ratio is performed on your planar imaging, and you draw a circle encompassing as much of the myocardium as you can, and then you draw a background area on the contralateral chest, or as it was historically called, the contralateral lung. You want to be careful to avoid the rib reflection sort of out at the periphery, as well as avoid the right ventricle. So it can be a little bit problematic to draw that circle. But the heart to contralateral lung ratio is calculated as the mean counts in the circle drawn over the heart to the contralateral chest or contralateral lung. And it's important to know that the HCl ratio is insufficient alone to diagnose ATTR cardiac amyloidosis. You should not use it if the visual grade is 0, because it would really be artifactual. If there is visual grade 2 or 3 uptake, then even a equivocal HCl ratio would not define a negative study. So you would still call that positive due to the visual grading. So I feel like it's less important in those times, unless you're trying to use it for prognostic purposes. And there is prognostic value to the HCl ratio. So we often report out the score, but just put it into context. And then where it's also helpful for diagnosis is when you have a visual grade 1 or 2 that's kind of equivocal between the two. And then you can use a cutoff of greater than or equal to 1.5 at 1 hour, or greater than or equal to 1.3 at 3 hours, to help definitively grade the study as positive or negative. And as I'd mentioned, it's useful in prognosis. So just to highlight the importance of SPECT reconstruction, in this case, you can see a heart to contralateral lung ratio of 1.2. And admittedly, when you start having more experience with these, you can see the myocardium is actually probably right here. And so this is not really a correct HCl ratio. When you look at these are the 1 hour SPECT images on the axial here, you can see that there's blood pool. And if you look here, you can see the myocardium is sort of in white. And then if you can see the sagittal, sort of the same thing, myocardium in white. We've got the blood pool cavity here. And then again, for the anterior view, and so the coronal view. And when we did a 3 hour image, you could see it's very clearly negative. So again, you certainly can do imaging at 1 hour, and especially if you have CT and probably some clinical experience, it is definitely able to be done in experienced labs. I would suggest, if you're just getting started, that imaging at 3 hours is maybe a little bit easier. And so for reporting, there are 5 key elements that you want to include. One is demographics, including the reason for the test, prior imaging results, biopsy results. You can put a lot of information in here, or just a smaller amount. Obviously, baseline demographics are important. You want to include the methods, including the radio tracer dose. You want to include the interval before imaging was performed. Was it done at 1 hour, 3 hours, both? You want to make sure that you mention that you did both planar and SPECT imaging. And certainly if you do CT for attenuation, as part of localization, then you want to include that. Then you have a findings section, and you want to mention image quality. You want to provide the visual scan interpretation confirming that there was diffuse myocardial uptake. You then want to have a statement on the semi-quantitative visual grading. Remember, that was the score from 0 to 3. And if you perform it, you should provide the quantitative HCl ratio. I think it's important that if this is contrary, so if you have a visual grade 0, we typically will not report the HCl ratio unless it's less than 1. If you are going to include it, you need to provide some kind of clarifying statement to make it clear, whether you think the test is positive or negative. And so you want to, and then ancillary findings, so whole body imaging, report if the planar images were acquired of the whole body, and interpret the CT if it was used as part of the study. And then you provide a definitive concluding statement. So the conclusion, the overall interpretation can be listed as not suggestive, which is a visual grade of 0, equivocal, which is a visual grade 1, or an equivocal visual grade 1 or 2 with a negative HCl ratio, or strongly suggestive, which is a visual grade of 2 or 3, where your HCl ratio, or excuse me, a visual grade 1, where the HCl ratio is strongly is positive, then you would call that strongly suggestive. It's also really important to provide 2 other statements. One statement, which is absolutely essential for your report, is a statement that evaluation by serum free light chains and serum and urine immunofixation is required in all patients to rule out AL amyloidosis, because any degree of uptake can be seen in AL amyloidosis. And an optional statement, but one that we find helpful, is that the results should be considered in the context of prior evaluation, and referral can be considered to a hematologist or amyloidosis expert if the echo or CMR is strongly suggestive, but the PYP scan is not suggestive or is equivocal, or if there are abnormal free light chains or the free light chains are equivocal. And just to highlight again, any degree of PYP, DPD, or HMDP uptake is possible with AL cardiac amyloidosis, which has to be ruled out. And this is an example from Gilmore of a diagnostic algorithm that makes sure to incorporate performance of that lab testing. So with that, I am going to, let's get into the cases, and I'm going to turn it over to Ed Miller. Ed, thanks.
Okay. Thanks, Jamie. I think you have to stop sharing your screen.
Yep. Let me.
All right. Thanks, everybody. I'm going to go over a couple of cases really quickly. We have a nuclear cardiology lab here at Yale that incorporates both SPECT CT as well as outpatient laboratories that have traditional Anger cameras. So I'll present the data from our cases from both of those types of scenarios. I do have disclosures from funding from amyloid treatment companies. This is just a great slide to begin with. This is showing an explanted heart of a patient of ours with V142I ATTR cardiomyopathy, showing the profound extracellular matrix deposition that causes the heart to remain fixed and dilated even after it's taken out and the blood is removed. So it shows you, even when you put on this big multi-liter jar of saline, that the heart doesn't compress. It shows graphically what the disease that we're dealing with. Let's start at case 1, a 75-year-old white woman, a history of heart failure with reduced ejection fraction, pacemaker, paroxysmal SVT, presents with progressive dyspnea. So it's not entirely a classic scenario. The demographics are not in a high risk category, she being female and Caucasian, though she does have a history of conduction disease and LV dysfunction. So this is the initial 1 hour anterior on the left and lateral images taken from a planar Anger camera. And what you can see here, these are very difficult to interpret if you're not used to taking a look at a lot of these. You see that there's the sternum here, and you see that there's this shadow of some degree of cardiac uptake. And again, these are taken at 1 hour. So I think that this is a scenario where these may be interpreted as equivocal, or in some cases, unfortunately, interpreted as having some degree of myocardial uptake. So how do you figure this out? Well, Jamie mentioned the heart to contralateral chest ratio and the problems, and this is an example, a bad example from our lab about how this was performed. This is our heart to contralateral chest ratio quantification scheme, and you see that our technologist did a really terrible job here, right? The contralateral chest ROI was way outside the lungs, and the heart ratio included part of the lungs as well. So obviously this is an artifactual and non-interpretable ROI, heart to contralateral chest ratio. So our 1 hour imaging in our laboratory with SPECT CT is followed by a SPECT acquisition on a CZT SPECT CT camera, which obviously very few places have, but it allows us to do SPECT CT image and image fusion. And any SPECT CT camera will allow you to do an emission transmission fusion scenario. And this is that fusion image. You can see the emission image here in cool, and then the transmission CT in the background. And you can see that there's clearly no myocardial uptake. In fact, it's hard to know exactly where to place the fusion in the correct three-dimensional context. But here we're getting pretty close to showing that there's no myocardial uptake, and this is a negative study. When we do the SPECT reconstruction itself, which can, again, with mild uptake can be difficult to interpret, but this is the SPECT as best we can account for the SPECT acquisition in the region of the myocardium. And you see that this is all blood pool activity shown on the vertical long axis images. Some summary from that case, it's an equivocal planar study that needs to go on for SPECT acquisition. We did a 1 hour image because we have SPECT CT, and the SPECT CT fusion image was negative. Second case is this is a case of ancillary findings. This is a 48-year-old man with AFib, LVH, and non-sustained VT. So demographically, if you were thinking this was ATTR, it would almost, by definition, have to be a patient with a TTR mutation given the age. Here is the 1 hour planar image, anterior and lateral. You can see there is a lot of rib uptake here, but you also see this photopenic space on the inferior aspect of the heart on a planar image. And so this is the quantification scheme. Again, difficult to interpret the HCl ratio with no cardiac uptake, as Jamie mentioned. And the extracardiac finding here is obviously a pericardial effusion that is responsible for that photopenic area. So I saw that someone asked a question about extracardiac uptake or extracardiac features. This is one of the things you can pick up on planar imaging, pericardial effusions and or ascites, pleural effusions, etc. So in summary, this was a negative planar case with a HCl that was negative, but it was difficult to interpret. And we evaluated the extracardiac findings that were noticed on the planar image. Case 3, this is a case of 1 and 3 hour imaging. So a 75-year-old man, diastolic heart failure and mild LVH on echo. Here's the planar anterior and lateral acquisitions taken at 1 hour. So an anterior and lateral. You notice we are using a 256 by 256 matrix, which is part of the recommendations as well to increase the matrix size. You can see again, there's a little bit of a cardiac uptake shadow here, and you're not quite sure what you're dealing with. When you go ahead for 3 hour imaging, though, it becomes quite clear that uptake shadow is much less prominent than the ribs, and it essentially goes away. We can look at the tomographic raw movies as well and show that there's really no evidence of cardiac uptake. And then the SPECT taken at 3 hours, again, confirms that there's some chest wall, or this is actually the ribs and sternum uptake that we're seeing as part of the SPECT acquisition, but no myocardial uptake to account for the mild degree of signal seen in the anterior planar projections. So in summary of this case, we had an equivocal low-level pyrophosphate imaging on 1 hour imaging. The 3 hour imaging really helped us to differentiate blood pool from cardiac uptake. And in this case, the review of the tomographic SPECT and SPECT images was really helpful. This was done on a non-SPECT CT camera, and we recently made the decision on our non-SPECT CT cameras that we are doing 3 hour imaging as a preferential imaging incubation period because of these issues of specificity. So my last case is a 90-year-old male. So getting into the demographics where TTR is going to be very prominent with history of atrial fibrillation, HFpEF, and actually kind of spuriously heterozygous for a mutation that causes iron overload. So concern about hemochromatosis with severe LVH and poor myocardial nulling on prior CMR. So the myocardial nulling aspect of it went along with ATTR and not iron overload diseases. 1 hour PYP planar acquisition shows clear-cut 3+ visual uptake in the anterior and lateral projections. Quantitatively, we see a nicely placed ROIs in the heart and contralateral chest in a ratio of 1.6. And then on our SPECT CT acquisition, this very clearly shows a significant myocardial uptake. It looks like a perfusion image. Again, you will see some uptake in the bones, and that's okay. But when you reconstruct this as a SPECT image, it actually looks like a perfusion SPECT. So those are my cases. Thanks to ASNC for putting this on, and my co-presenters. I yield the floor, Dr. Bourque.
Thank you, Ed, and thank you, Jamie. I'm Saurabh Malhotra from Cook County Health. Good afternoon and good morning to those in the Central and the Pacific time zones. I'm going to talk about when SPECT imaging is critical. As a disclosure, we've been performing SPECT from the get-go for the last 5 years, ever since we started doing PYP imaging. It stemmed more from curiosity, but then we solidified and realized that SPECT imaging is the way to go. And you'll see that all our recommendations now are centered around performance of SPECT. These are my disclosures. So just to quickly review where planar PYP scintigraphy and its diagnostic role in TTR cardiac amyloidosis stems from. This is from the Gilmore paper in 2016, a multi-center study, thousands of patients, showing that if you have a grade 2 or 3 visual grade uptake on the PYP scan in the absence of paraproteinemia, or once you have ruled out AL amyloidosis, is highly specific for TTR cardiac amyloidosis. I would say more than 99%. Nothing is 100%, but it's right up there. So this is where the application of PYP TTR for TTR cardiac amyloidosis was really engraved and strengthened. Now, new recommendations, as Dr. Bourque pointed out, recommend performance of SPECT imaging if planar is positive. That is a requirement now, and this is to confirm myocardial uptake and differentiate the myocardial uptake from blood pool activity. The question that comes to my mind is, what is myocardial uptake on PYP imaging? So I'm going to share some examples here with you all. These are images from 4 different patients, all of whom presented with heart failure, who were referred for PYP and scintigraphy, grade 0, grade 1, grade 2, and grade 3. Whom should we perform SPECT on? Now, traditionally, grade 2 and 3 uptakes would be classified as being positive, so at least that's what the prevailing understanding is from a specificity standpoint for TTR cardiac amyloidosis, while grade 0 is definitely negative and 1 could be indeterminate or negative. Looking at their SPECT images, of course, no surprises. Those patient with the grade 0 uptake had no myocardial uptake. This is all blood pool activity. Patient with the grade 2 uptake also had blood pool activity with no myocardial uptake. And so was patient with a grade 3 visual score. This actually looks like a MUGA when you do the tomographic reconstruction. And surprisingly, the patient who actually had the grade 1 uptake had tomographic evidence of myocardial of PYP uptake on the SPECT imaging. Strikingly, a patient with the grade 0 actually had an HCl of 1.9, and if you review the planar images, you see that the patient actually has a photopenic region in his entire right lung, which is actually a pleural effusion, talking about extracardiac and non-cardiac findings, and placement of an ROI in the contralateral chest with pleural effusion markedly diminishes the counts coming from that side and spuriously elevate your HCl ratio. So again, just to show why planar imaging, specifically HCl ratio, can and will produce spurious results if not confirmed by SPECT. So we have shown this in our analysis of data from 2 centers that we had access to. We showed that among patients who were PYP positive, a fraction of patients, a small proportion, could be missed just by visual or Periguni score. whereas those that were negative could be falsely classified as being positive just by visual score assessment. HCl ratio performed actually even worse among patients who were SPECT positive. About 40% would have been classified as negative or indeterminate by the HCl ratio. Now, while the classification by Perugini score is pretty good, if you combine the entire planar data, including the visual scoring and the HCl, you will end up calling a lot more cases as being indeterminate unless confirmed by SPECT imaging. So going back to the same slide from showing the specificity of PYP scintigraphy, we all focus on the specificity of pyrophosphate imaging, but we often omit the sensitivity. This study actually showed that if we have any PYP uptake that is 99% sensitive for cardiac ATTR, in the absence of monoclonal proteins, that's even more relevant. Now, this is because patients with a grade 1 visual score may also have evidence of SPECT evidence of myocardial uptake, which could be seen in patients who have early disease. So talking about the 1R and 3R issue, we have been performing 1R imaging alone with both planar and SPECT for the longest time. We started off by doing both 1R and 3R imaging, and we performed it for almost an year, and then we realized that at least in our experience, there wasn't much difference. There was actually no difference, and that has been studied in a large observational study performed at University of Pittsburgh. So this is a case of a 65-year-old gentleman with heart failure and reduced ejection fraction, 25%. That's important to note. History of hypertension, chronic kidney disease, again, important to note. In this patient, we're going to talk about why. Diabetes, no obstructive coronary disease on a prior angiogram, could not undergo cardiac MRI due to claustrophobia, had multiple, was compliant with heart failure medications, had no heart failure admissions, had neuropathy, was wheelchair bound, but was presumed to be from diabetes. EKG shows sinus rhythm with low voltage to relatively low voltage EKG, no history of carpal tunnel syndrome, lumbar stenosis, orthostatic hypotension, or GI disturbances. This is his echocardiogram showing severely reduced ejection fraction, biatrial dilatation, some thickening of the valves. Wall thickness was measured to be about 1.2 centimeters, so not terribly thick. However, he did have an apical sparing pattern on his strain imaging, which is performed in almost all our cases in our lab. So based on this finding, he was referred for further evaluation of cardiac amyloidosis. So this is an image from the time when we were doing both 1R and 3R imaging. This is 1R images, in planar image showing grade 3 uptake with an HCl ratio of 1.33. And at that time, we were performing 3R imaging as well, so which was, again, images shown here. This is now grade 2, which is anticipated, but still both will be considered positive if you look at the visual grade, negative if you just go by the HCl ratio, or indeterminate if you combine both. However, SPECT clarifies these findings. SPECT imaging at 1 hour showed that this is all blood pool activity. There was no myocardial uptake. And even at 3 hours, it showed that this was all blood pool activity. And the blood pool activity was pretty persistent even at 3 hours. And this is likely because of patient having chronic kidney disease, which is what you need to clear the tracer is normal renal function, and also probably from the severe left ventricular dysfunction. So just because we perform 3R imaging doesn't mean there may not be blood pool activity, intense blood pool activity at 3 hours. Moving on to the theme of use of SPECT-CT. This is an example that was shared by my colleague, Dr. Akinjolu from University of Western Ontario, of a SPECT-CT, PYP imaging, the SPECT-CT system, grade 1 Perugini score, a low HCl ratio, no significant visual uptake on PYP SPECT, and correctly identified as blood pool with the hybrid imaging combining SPECT and SPECT-CT. On the flip side, you have a patient who has a markedly positive planar image, and in this patient, not only does SPECT-CT imaging correctly identifies all the counts to be coming from the myocardium, but also identifies faint uptake in the right ventricle, which has been shown to be associated with a worse prognosis. So When is SPECT imaging critical? In my opinion, SPECT imaging is essential, should be performed in all cases. Planar imaging alone can misclassify PYP scintigraphy. Tomographic imaging improves diagnostic certainty due to the ability of SPECT to differentiate blood pool activity from myocardial uptake. In our opinion, and in our experience, actually, it obviates the need for 3R imaging. Given the diagnostic, therapeutic, and prognostic implications, all planar findings should be confirmed with SPECT. And as mentioned, if you have SPECT CT, if you have access to SPECT CT, you should preferentially use SPECT CT if available. Thank you, and I'm going to pass on the stage to Dr. Sperry.
There we go, unmute. Thank you, great talk. Let me pull up my slides here. Here we go. All right, so thanks everyone again for allowing me to talk here. For the last part, I'm going to talk about some real world cases that I've seen over the course of the past 6 months of patients where a PYP scan has been misinterpreted, and just so we can all look at things and talk about what are some of the pitfalls here when interpreting these in the real world. And I think a lot of this comes down to what you've heard over the course of the past 30 or so minutes, as far as really needing to look at the SPECT images. So the first case here, this is a 59-year-old white female who has a history of hypertension, heart failure with preserved ejection fraction, and presented as a consultation to me for amyloidosis. She was diagnosed 3 months prior with at an outside hospital and was started on stabilizer therapy. So this is her scan that I was able to receive the images from, and you can see the heart to contralateral lung ratio here is reported as 1.6. These are both AP views, and then here's the lateral view. They call this a grade 2 uptake, and I think that's probably right. You know, especially on the lateral, you do see the heart, and you have an HCl ratio of 1.6, and so given these two, this was reported as consistent with ATTR cardiac amyloidosis. So what about the SPECT images? And I apologize, this case doesn't really have, I don't have great quality of these images, but you can see here, I just outlined for you the kind of the negative reflection there of the myocardium. And so all of this that you're seeing there is in the blood pool. It's in the LV cavity and the RV cavity, et cetera. Very clearly seen there on the SPECT images. So this was a case of a true false positive PYP on planar, where both the heart to contralateral lung ratio and the semi-quantitative score were technically positive, but the SPECT was negative, and confirmed that. And so she was taken off a TTR stabilizer. The other thing is, like we've been talking about already, is what's the pretest probability? You know, the consensus document was changed a little bit, as Dr. Bourque was talking about earlier, with as we're scanning patients with lower pretest probability, and this patient, this is a female, a fairly younger female, white female, so fairly low pretest probability for ATTR cardiac amyloidosis. This is a case 2, 68-year-old white female with symptoms of dyspnea exertion. Septal thickness was 1.9, posterior wall thickness was 1.0, LVOT gradient was 66, so she was diagnosed with hypertrophic obstructive cardiomyopathy. The PYP scan was done to evaluate for ATTR cardiac amyloidosis, it was read as positive with a plan to start TTR tetramer stabilizing therapy, and she sought me out for a second opinion on this diagnosis. This is the planar image here, and this was read as a grade 2 study with an HCl ratio of 1.2, and the report said it was consistent with ATTR cardiac amyloidosis despite a low HCl ratio, and this is a false negative HCl ratio. So this is raising red flags here. You know, I don't really see much cardiac uptake there, and these are the SPECT images where you don't see any cardiac uptake, and I'm just going to blow up some of these images. And similarly, you can see this is a SPECT CT even, and you really don't see any significant cardiac uptake there. And again, on the top image there, you can see the negative photopenic reflection of where the myocardium is in the short axis. This is a negative study on both planar and SPECT, and we reassured the patient that she did not have this disease, and she was not prescribed therapy for this, and she was actually then referred to our HCM center for further treatment of that. This is our third case here, 72-year-old white male with atrial fibrillation, ejection fraction 55%, septal thickness 1.1, posterior wall 1.1. So this patient, the demographics fit a little bit more for amyloidosis. It's an older white male with some cardiovascular disease, but the LV wall is not very thick, and the troponin and NT-proBNP are fairly low. Again, PYP scan was ordered here. Again, it was read as positive and came here for a second opinion. These are the pictures, lateral and AP, and it was interpreted as strongly suggestive of TTR amyloidosis since myocardial uptake is equal to the patient's ribs, even though the ratio was 1.29. So again, you know, something we need to hammer home here is that if you really shouldn't be calling it on the planar at all, only on the planar images, and then you know, you to have true certainty, you need to have both the planar HCl and the semi-quantitative grade be positive. I think I do see the heart a little bit there, but I wouldn't say that it's very strong, or certainly not grade 3. Here are the SPECT images that were acquired, but not reported on, and these are clearly negative. I don't see any cardiac uptake there. It was 1 hour and 3 hour images. Again, don't see any cardiac uptake, and we see bone uptake. So again, negative PYP on planar images that was misinterpreted as positive, and the SPECT images confirmed a negative scan, and the patient was not prescribed a TTR stabilizer. Fourth case, again, these are literally all cases I've seen in the past 5 or 6 months. This is an 82-year-old white male with atrial fibrillation and heart failure with preserved ejection fraction. Ejection fraction was a little bit low, 49%, septal thickness and posterior wall a little bit high. So here we're really thinking the pretest probability is a little bit higher than the prior cases. You have a borderline ejection fraction, septal thickness is increased, and an older white male with heart failure. So here appropriately, PYP scan was ordered, was read as positive, came for a second opinion. Here's the planar AP image. This was read as grade 3 uptake, HCl ratio 1.69 at 3 hours and 2.15 at 1 hour. This is the 1 hour image here, read as strongly suggestive of TTR amyloid. I already questioned this because you could almost even see the blood pool in the middle here. I don't know if you can see my cursor, and then more of the similar negative reflection of photopenia around where the myocardium would be. Interestingly, this is how the HCl ratio regions of interest were drawn. So as you've seen in the previous talks, this is much too small. They probably picked up a hot area in the blood pool here and found a relatively photopenic area over here. So these ROIs need to be much bigger. An inspect was performed, but not reviewed by the interpreting physician, and also not available for me to get because they switched cameras, I guess, and deleted all the SPECT reconstructions from them. So I was not able to obtain the SPECT images. So we repeated a PYP scan here at our institution and a clearly negative scan on the SPECT images. So for this case, I said unclear interpretation of the outside PYP scan, as no SPECT images were saved, and the repeat study showed a clear negative on both planar and SPECT. And they had been prescribed actually TTR stabilizer therapy and had not picked it up yet. And we told them that patient didn't need that. So this is my summary slide, which goes along with what others were saying on here today, which is we really need to be looking at the SPECT images to decide whether this is a positive or negative scan. I think that hopefully webinars like this and others that we've done through ASNC and other institutions and organizations will help spread the word that we really need to be looking at all the data that's acquired. I think for these studies that I've shown the SPECT was acquired on all of these, but I don't know that it was actually being looked at or interpretation was based on that. So more plugs for looking at the SPECT images to decide how we're going to diagnose this and potentially start people on fairly expensive therapy. Thanks.
Thank you, Brett. And I will just briefly share my screen here. Just to point out, we've included a reporting template in here for you. This was one of our reports and just highlights the interpretation summary or concluding statement that includes the fact that there was no myocardial uptake, includes the visual grade, includes the HCl ratio because we performed it, and because it was consistent with the visual grade of 0 being less than 1, we didn't have to add a lot of other interpretation. And then a final definitive statement that findings are not suggestive of cardiac ATTR amyloidosis. We then include the statement on evaluation of AL amyloidosis. There's been some robust discussion in the chat about this, and we will definitely get to it in a second. And then the comment about interpreting in the context of prior evaluation and when to consider referral to hematologist or amyloidosis expert. So we are now ready for our panel discussion and audience Q&A. There's already been a very good robust discussion going on in the Q&A, but I'm going to stop sharing my screen here for a second and invite our panelists to unmute and jump into the fray. So the first question, there's been a lot of discussion about solid state cameras and some of the particular issues that come up, and I thought it might be worthwhile. We don't use a solid state camera for our amyloidosis imaging. So I'm curious to the panel, what are some of the unique considerations that have come up, and how have you addressed them?
Yeah, so I'll take that on. So we have a GE 530 and a 570 system. The 570 is the 530 with the CT on the back end of it. So I can only speak to that. I can't speak to the DSPECT, which I think will have other issues. Obviously, the main one is you don't get a planar image. There are some ways of doing a pseudo-planar reconstruction, but it's kind of technically complex. So you're not going to get the heart to contralateral chest ratio, which is the main issue. And then it's for the 530 camera, it's patient positioning, making sure that you have the heart in the field of view, where if you don't have cardiac counts, that can be something that the techs need experience to figure out. With the DSPECT, and correct me if I'm wrong here, it may actually error out if there aren't any cardiac counts because it's looking for cardiac counts that may not be there. So that would be the issue that you come across. So, we're in a unique position where we have an ANGR camera and a CZT camera. And so we do our planars first and then we used to, if the planars were negative, we would not do the SPECT because of all the issues we come across. We're now doing SPECT on everybody. So that's one of the ways we approach it. But it's certainly reasonable to do CZT only, but you just have to, you're going to have to spend some time to understand what you're looking at. And there was a question about position paper. I actually checked back, Jamie, and we didn't actually talk about CZT in the imaging guidelines. I don't know if you have a reference for CZT. I know that we haven't published one. There was data, Brett, when you were at Cleveland Clinic, do you guys publish on CZT there?
No, we have a standard anger camera, a cardio MD camera here that we use at Mid-America. We also have a D-SPECT camera at our CZT at our satellite hospitals. And if we really needed a PYP done at one of our satellites, we have done a few of them on the D-SPECT camera. The problem, like you mentioned, it's a very small field of view and you really need to know exactly where the heart is. And if you are injecting a radio tracer that has no cardiac counts, it's hard to exactly position the camera to know where it is. I know Cedars has published a study with the D-SPECT injecting a little bit of thallium first to localize the heart, and then
I forgot about that. Ron Schwartz, thanks for mentioning that. It's a great idea and something very useful to do is the dual isotope. Well, we don't dual isotope in other cases is verboten, but in this case, adding a little bit of thallium to the image to show the heart contours can be really, really helpful. So thanks, Ron, for bringing that up again. And you have published on that, and as a Cedars group, to show how you can do that to localize the heart.
And there are references out there for use of CZT cameras, and Joe and Linda, I think it'd be helpful if afterwards, if we could send something out with those references, that would be great. We can provide those for everyone. Another question that has come up and received a lot of question, and this really gets back to one of the main issues that we addressed in the addendum, and I talked about this a little bit in the beginning of my talk, was consideration of whether to do 1 or 3 hours. And I would say that there was definitely robust discussion on this when we discussed for writing the addendum to the document. And the final determination was that we were going to recommend 2 to 3 hour imaging. And the predominant reason for that was that there are a lot of labs that are getting into this imaging technique. And a lot of them are not necessarily using CT for localization. And the thought was that that is certainly the easier way to get into into imaging. And there are definitely some places, such as Brigham and Women's, where I am at UVA, where we're using predominantly 3 hour imaging. However, as you've heard from our experts on the talk, there are definitely well-respected and excellent labs that are doing 1 hour imaging and having very good results with it. So I think Dr. Miller had suggested that if you're sort of getting into the technique, it's probably worthwhile. And what we did for a long time was image at both 1 hour and at 3 hours, so that we could start getting familiar with sort of what we were seeing with the two, but also to see sort of which we liked better. Is to do both, or to start out at 2 or 3 hours. And then certainly for efficiency purposes, if you become very skilled at this, you could consider moving to 1 hour. That would be my recommendation. I'm curious if our panel has any other suggestions or thoughts on that.
Jamie, I would agree with you that I think if you're starting off, and given the concerns with blood pool, I think it might be prudent to at least do 1 and 3 hour imaging with SPECT, by the way, not without.
Yes, absolutely.
And once you figure out what your lab throughput was, and we did it for some time, and it was not congenial for our lab throughput. And we didn't see any diagnostic differences in a 1 hour and 3 hour scan. So that gave us the confidence that we could continue doing just 1 hour imaging which provides the same diagnostic quality, which is published now, by the way, by several sites, and then improves the lab throughputs. But I think if you're starting fresh, it might be worthwhile considering doing both 1 hour and 3 hour.
You really learn a lot, but if you do those, we did, I remember when we first really started this 2015, 2016, you do the 1 hour and 3 hour and 20 patients, just the first 20, and you really get an idea of the differences and what you need to do. So I would strongly recommend that. And then most people will probably end up choosing to do 3 hour spec. Some people will probably end up choosing to do 1 hour spec too, but most people probably end up at the later time point.
And that's what we did here too. When we were deciding about the 1 versus 3 hour, we did a bunch of patients at both 1 and 3 and looked at everything, and had our nuke docs have blind reviews of the 1 and 3 and the spec and everything, and really get comfortable with looking at the 1 hour. And certainly during COVID, it's really pushed us to go to 100% 1 hour studies here, because keeping people in the waiting room for multiple hours and everything is not ideal. So yeah, we've moved to the 1 hour, but definitely if starting off, I agree with the panel that getting a good sense of what a 1 looks like, what a 3 hour looks like, and then going from there.
Excellent, thank you all. Other questions and some already robust discussion in the chat has occurred considering the timing and interpretation of the serum free light chains and the serum and urine immunofixation that is performed for assessing for AL cardiac amyloidosis. I'll just make one comment that we had not addressed initially, is that it's very important to specifically do the immunofixation, the serum and urine immunofixation. That is not enough to do an SPEP and UPEP. And I have to say, at University of Virginia, at least, we got a lot of pushback initially from our lab about performing the immunofixation in all patients, and had to really explain to them and show them data about the importance of why it's not sufficient to stop with just the SPEP and UPEP. And so that's something that you may need to work out with your institution. And so I put up for the panel questions about when you are performing the AL lab testing, and also any unique considerations in terms of interpretation, particularly in patients with renal disease.
Yes, so Jamie, we do this routinely in all patients. We have a shotgun approach. If anybody is referred for a PYP scan, they all get serum kappa lambda evaluated. And our lab, by default, if the serum kappa lambda ratios are elevated, even though not to the extent one would see in AL amyloidosis or myeloma, and you may see CKD patients, our lab defaults to performing immunofixation, electrophoresis in all those patients. And the key there is to see if there is an expression of a specific chain. That is what myeloma is. You can have elevated ratios because of chronic diseases. You can have elevated ratios from MGUS, which we have seen in a large proportion of our patients, but what we need is an overexpression of a particular chain. And if you have that, or if your ratios are too high, I have a low threshold to reach out to a hematologist, and I think that should be encouraged. Again, you have to be really sure that you are confident that you have ruled out AL amyloid or any precursors.
Yeah, you'll become much more friendly with your, if you aren't already, with your hematology colleagues as you get into this, because about 20% or so in published data of patients referred for PYP scanning have evidence of a circulating monoclonal protein, usually an MGUS, and that's certainly not something that you want to take on most of the times as a cardiologist to follow. It really needs expert opinion and expert guidance into how to evaluate that most completely and to follow it.
All right, well, thank you all. And I'm going to share my screen one last time. So I think we're about out of time. So we want to thank you for attending our webinar. And hopefully on the screen, you can see SurveyMonkey sites for both our webinar evaluation, as well as a technetium PYP imaging survey that we'd please ask you to undertake. And want to thank Pfizer for their support of this activity. Want to thank ASNC for sponsoring, and in particular, I want to thank my fellow panelists and speakers for a really engaging conversation and excellent cases. I want to thank all of you all for participating and going out and starting these programs. This is a really important thing for us to be providing, a service for us to be providing, and I think it's an exciting time for nuclear cardiology. So thank you very much for attending, and enjoy the rest of your day.
Thanks. Bye-bye.
Thank you.